Management of deep vein thrombosis. The most important parts of the questions of the management of deep vein thrombosis are when to start anticoagulation, how to manage a specific DVT, and for how long. In 2012, CHEST guidelines made a specific recommendation that risk assessment should precede any diagnostic test. Based on this recommendation, we developed this algorithm at Jobs Vascular Institute that specifically assigned the probability of DVT to different categories of the risk assessment and the need for venous ultrasound that assigned to the same categories. You can see that negative D-dimer and Wells score combined can predict negative DVT with accuracy more than 99%, which is much more accurate than any ultrasound or otherwise imaging modalities. Therefore, in those low-risk categories, we do not recommend venous ultrasound at all. In the high-risk category, however, ultrasound is necessary, but it can be delayed to up to 48 hours, and the management could start immediately. Have to notice that the level of recommendation in CHEST guidelines, as well as in many other guidelines, is not very high. There is no level A evidence-based guidelines in the 2016 recommendations, and the majority are either level B or C. For proximal DVT, the recommendation is to start anticoagulation and to continue anticoagulation for 3 months. The choice of the drugs, though, can be different. For the majority of patients, DOACs is the first choice, or vitamin K inhibitors as a second choice. But the cancer patients still remain low molecular weight heparin as a first choice. If the DVT is caused by a transient risk factor, after 3 months, anticoagulation can be stopped. However, if the DVT caused by a non-transitional factor, such as unprovoked DVT or cancer-related DVT, then the risk of bleeding should be assessed at 3 months. If the risk of bleeding is high, anticoagulation can stop. If the risk of bleeding is low, then extended therapy is recommended. However, if the extended therapy is stopped either by the patient or by a physician, then the aspirin may be a drug of choice to continue manage these patients indefinitely. This recommendation came from large epidemiological studies that show that the recurrent DVT or recurrent VTE events is the major cause of death in patients who have at least one episode of unprovoked DVT. More precise studies demonstrated that recurrence of DVT is actually higher than recurrence of PE, but in combination, both of them present a substantial risk for the patient. Therefore, patients should be managed by anticoagulation as long as possible. Many studies, especially DOACs randomized studies, show that if the anticoagulation stops, the annual risk of DVT is about 7 to 10%, and it decreases to 1 to 2% by continuous anticoagulation. Of course, not all patients can continue anticoagulation indefinitely. Currently, only few risk factors are known, such as male age and increased D-dimer after discontinuation of anticoagulation, that indicate that patients are at highest risk of recurrent event and should be continued on anticoagulation indefinitely. Management of the CAF DVT is different. It based on the risk of extension, risk of bleeding, and symptom severity. Several factors are identified as the risk factors for extension of DVT. They are listed on this table. So if the risk is high and the risk of bleeding is low, then the CAF DVT can be managed the same way as the proximal. You can see if the risk of bleeding is low. Same is true about the severity of the symptoms. High severity of the symptoms usually indicate high risk of extension, and in combination with the low risk of bleeding should be indication for 3 months of anticoagulation. However, in all other patients that have low risk of extension or high risk of bleeding, or the symptom severity is low, then the serial imaging within 2 weeks repeat of ultrasound may be a choice of management. And the important change of this, if extension happen, then it's switch back to the management with anticoagulation for 3 months from the time of the diagnosis of this extension. However, because there is no solid evidence for either serial imaging or anticoagulation is the best management for isolated calf DVTs, patients should be given a choice between those two modalities. While given this choice in the specific circumstances, cost of care also should be considered. In some institutions and countries, serial imaging may be more expensive than anticoagulation and vice versa.